Hey, karibuni sana. Good evening, ladies and gentlemen. Welcome to the KMA Physician Wellbeing Committee, CME. As we approach the World Bipolar Day, which will be on March 30th, 2025, the KMA Physician Wellbeing Committee has curated a special webinar featuring a client with lived experience. This session aims to bring the reality of bipolar disorder closer to home, followed by an in-depth discussion that will provide insights into the condition, raise awareness, and highlight the importance of recognizing early signs and seeking timely support. Karibuni sana tena, and as you join, I would like to let you know about a few housekeeping rules. One, kindly mute when you join and ensure that your cameras are off. And for all the questions that you might have, feel free to type them in the Q&A section. And for any comments or take-home messages that you might have, please type them in the chat box. My name is Dr. Chepto Kogo, a committee member of the Physician Wellbeing Committee, and I will be your moderator today. As we wait for the others to join, allow me to share about the committee and its mandate. So the Physician Wellbeing Committee is dedicated to promoting the mental, emotional, spiritual, and physical well-being of all doctors in Kenya, as we champion for their welfare holistically. This committee addresses critical issues that impact the overall health of doctors, such as doctor burnout, stress, mental health challenges, lack of adequate adversity quotient, and the elusive work-life balance. It advocates for the implementation of wellness programs and provides resources such as virtual webinars on mental and occupational health, physical exercises and games such as soccer, golf, team building activities, and the KMA choir. And it works to create a supportive community within the medical profession to ensure physicians thrive both personally and professionally. The vision of the committee is to cultivate a culture of holistic well-being among doctors, ensuring they experience fulfillment, resilience, and balance in their professional and personal lives. Our mission is to empower Kenyan doctors by fostering a supportive environment that prioritizes their well-being, enabling them to provide optimal care to patients while maintaining their own health and vitality. We stand on the mantra, physician, heal thyself. So currently, today's guest speaker is Dr. Eva Monique Musheru. Let me introduce Dr. Eva, who has a well-decorated bio. So she's a graduate of the University of Nairobi, Bachelor of Medicine and Surgery in the year of 2001, and a Master of Medicine in Psychiatry in 2006, during which she was awarded the Best Distinction Student in the year 2006 and 2007. She's a lead psychiatrist at Healthy Mind Consultants, a one-stop shop for one's mental health needs. She's also a founder member of Kamili Organization, a mental health NGO providing subsidized community mental health services, sponsoring nurses' higher diploma in mental health, and providing loans to clients. She's a consultant psychiatrist at Mathari National Teaching and Referral Hospital, and her interests include telepsychiatry, mental health promotion, and youth mental health. Besides pursuing her passion for mental health, she enjoys swimming, gardening, and creating memories through taking pictures. Dr. Musheru, the floor is yours.
Thank you very much, Dr. Chepto, for your kind introduction. This evening, we are privileged to celebrate the World Bipolar Day 2025. And I will start by a quote that, as Martin Luther King once said, "I have a dream that one day all our nations will rise up and create all men equal. And I have a dream that my son, who has lived most of his life with bipolar disorder, will one day live in a nation where he will not be judged by his illness, but rather by the content of his character. I believe that World Bipolar Day will help bring my dream to fruition. And to celebrate World Bipolar Day 2025, I'm joined by a guest who is one with living with bipolar mood disorder, and I would like him to introduce himself. Allow me kindly to shift the speaker.
My name is Samuel Boyo, and I'm 41 years old. I schooled up to Form 4, and I live with bipolar mood disorder. And I'm coping very well with medication.
Thank you, Samuel. Kindly let us know the following: your year of diagnosis, how many admissions you have had thus far, and the current treatment you're getting.
Okay, my proper diagnosis was made in 2004 at Malaria Hospital after many, like 4 years back of misdiagnosed. And after four years, then that's when I started medication. I have tried a lot of medication, one that works for me and the other does not work for me. They could have a lot of side effect. But currently or today, the one that I'm using today, they have less side effect that I can tolerate and I can be able to work as I use them. My current treatment, I go for antidepressant known as Droxetine that I take in the morning. In the evening, I normally take Ecroid Chrono 500 mg, Aripitas 7.5 mg, and also I take Fluanzol, a mother injection, and they help me with my mood stabilizing. And also, I have been admitted several times in Malaria Hospital since I started getting unwell, and it has, when I get there, I get also care. But since for the last 3 years, I have not got any relapse, so I have not been admission. My current admission, most of my admission are like 15 times in Malaria Hospital.
Thank you so much, Samuel, for shedding light. I would like Samuel to tell us in brief, what is his presentation? What kind of symptoms does he present with, especially prior to admission?
Most of the time, you will hear me talking about how I want to be the president, how I'm going to see Obama. Sometimes you feel you are very talkative. You think the radios are talking about you, and also you feel like you have a lot of money in the bank. You feel like no one like you. You are a very special person, but that is not the case. And yet, after that, I got into depression. You find yourself, you are locking yourself in the house, you don't want to eat, you don't want even to take a shower. You feel you are very hopeless. Sometimes even you contemplate of committing suicide.
Thank you, Samuel, for sharing with us that intricate part of your life, which is confidential. But I would like you to tell us about other treatments other than medication that have been of use during your journey.
Okay, there is something I call psychosocial therapy. It has helped me so much for the last 3 years. I have been going there for at least three months, once per 3 months. It has helped me with accepting my condition, and that's why I have not relapsed to the world for this time. Yes.
Thank you once again. Do you want to tell us about a support group?
Yes. We have a support group known as USP, Users and of Mentor and Survivor of Psychiatrists. I joined it in 2016. It is a group that we normally meet and share our diseases, we share our emotions, and it has really helped me to be sober the way I am today. So no going back to hospital again.
Thank you yet again for telling us about the use of support groups as being instrumental to your stability. Kindly tell us finally about what you do for a living.
Okay, finally, for a living, I am a salesman. I do business. I sell jewelries and shower cap. Even I sell to Dr. Mushero. And Malari Mental Hospital are very supportive for me. They have even given me that authority to sell to them. And I'm so happy that I do it very well today. But when I get unwell, I go back to zero. Everything that I have, I give it out, and which after that, you start over and over again. So mental illness, it has really affected me. But for this time, I'm so happy for the last 3 years. One, I have not relapsed. Second, my business is going well. And I hope I will not get ill again so that I continue with the, no, with the productive life that I'm living today.
Thank you very much, our guest with lived experience. It is indeed true that you can have many things from him and other of our patients with lived experience, that indeed people with severe mental illness do live a productive life and they need our support. So actually the reason for having today's webinar, among others, for World Bipolar Day is to raise awareness, to support those living with bipolar mood disorder, and to ensure that each of us know how we can support one another, whether you're living with bipolar or your kin has bipolar. And we would like to thank him for being our guest today. Then over to Dr. Cheptor. Thank you.
Thank you so much, Dr. Eva and the guest. So we are going to have a poll up in a few seconds, and you're expected to answer. It's not going to be really hard. It's something about bipolar, and then we're going to come back to the discussion with Dr. Musheru. Okay, I see we have gotten a few responses, and I'll share the results right now, and then I will allow Dr. Musheru to continue with the discussion after I share the results. So, Dr. Musheru, are you able to see the results?
Yes, I am able to see the results.
So you can continue. Let me stop sharing.
Okay, thank you.
Back to you, Dr. Musheru.
Please let me see. Let me know if you can see my screen.
Yes, Doc, we can see. You can continue, but I please get to the first slide. We are seeing risk factors.
Give me a moment. Kindly allow me to stop share and then reshare again.
That's okay, Doc.
I hope you can see me and see my slides.
Yes, Doc, we can. Please proceed.
Thank you. Unfortunately, they are not moving. So, World Bipolar Day was first celebrated in 2014 on the 30th of March. 30th of March is significant because it is the birthday of Vincent van Gogh, who was born on the 30th of March and was diagnosed posthumously with bipolar mood disorder. And the aim of this day is creating awareness, promoting understanding, and reducing stigma. So the theme for this year is bipolar strong or bipolar together, so that we are able to come together and support those living with bipolar. One, by educating ourselves, getting to understand the condition, and reducing the stigma. Use of support groups, use of webinars like this to ensure that people understand what bipolar and related disorders are all about and how we can reduce the suffering of our patients by prompt diagnosis. Now, on our poster, we had the ribbon, the green ribbon, which is for mental health awareness. But for bipolar mood disorder, for World Bipolar Day, sorry, we have a black and white ribbon. It's black with white stripes. Sorry for the typo. And the black represents depression, the laws of depression. The white represents the highs of mania. And now this shows, it actually shows the contrast between the two. My presentation is going to follow an outline where we look at how bipolar was first described, what are the prevalence rates, and why is it important that we talk about bipolar mood disorder? What are the risk and prognostic factors? What are the signs and symptoms? What are the differential diagnoses, the investigations, and management of the conditions? So I want to say that bipolar was described fairly early before Christ, and it was described as melancholia and mania. It was also first described, the first documentation was in 1851 by a gentleman called Jean Pierre, who termed it as folie circulaire. And folie is a term used to mean loss of touch with reality. And it is, why it was circular is because it was on and off. It was episodic. So this gentleman actually described the fact that it is not a continuous thing. So what we are going to describe today is a condition that waxes and wanes. So there is an interval present where the patient is fairly stable and can be functional. But there is a time when, during relapses especially, they are quite dysfunctional. Then it also was described as folie à double form, meaning two forms of both the highs and the lows. And this was later on, but this particular individual, the Jules, did not describe the interval that we now know today. It was then described by Treplin as manic depressive insanity. And there is what we are now going by today, the Diagnostic Statistical Manual for Mental Disorders, version 5, which is DSM-5, text revised, which brings us to our topic today, bipolar and related disorders. Back to the DSM, Diagnostic Statistical Manual, which is an American Psychiatric Association mode of classification. DSM-1 was described in 1952 as a manic depressive reaction. In 1968, it was described as a manic depressive illness. In 1980, manic episode and bipolar disorder. And as late as 1994, we were talking about it as bipolar disorder and a mixed episode. But right now, we are talking about it as bipolar and related disorders. So this is the current classification from the year 2022. But we live in a world where we have different classifications. We have the World Health Organization classification of diseases. It's called the ICD. We are at version 11. It's the International Classification of Diseases. And this is what you find in our in most of our information, like health management records or electronic medical records. The diagnosis will come in form of ICD. So you will be required to key in the diagnosis of bipolar affective disorder, which spans all the way from F31.0 to F31.9, depending on what the person presents with. So what we are trying to say is, for the sake of policy, for the sake of statistics, we rely on the ICD-11. So I want us to shed some light on both so that when it comes to clerking of patients, we are trained to diagnose them in DSM-5. But when it comes to documentation, the records officer will rely on ICD-11 to give a report about the number of patients with a certain diagnosis who have been seen in a certain facility or who have been receiving care and follow-up. Now, the bipolar 1 equivalent in ICD-11 still requires that you have one present or past manic episode or mixed episode for the diagnosis. If it is bipolar 2 equivalent, then you need at least one manic episode and one depressed episode. I will substantiate as the presentation continues. Now, back to DSM-5, we have various disorders described under this classification. The first one is bipolar 1. If you remember our guest, he talked about bipolar 1 mood disorder, and I will talk about how to diagnose bipolar 1 disorder and how to differentiate it from bipolar 2. Cyclothymia, bipolar and related disorders due to general medical conditions, substance or medication-induced bipolar and related disorder, other specified bipolar and related disorders, and unspecified bipolar disorder. What's the difference between the last two? Because that one I would need to declare it right from the beginning. If one does not meet the criteria for bipolar 1, bipolar 2, cyclothymia, bipolar related to a general medical condition or induced by a substance or medication, then this indication, or rather this diagnosis, would be under this other unspecified bipolar and related disorder. Why? Because it causes clinically significant dysfunction. So this person can't function at home, they can't function in school or at work if they are an adult, in school if they are a child, but they do not meet the criteria of the first four. No, the first five, sorry, bipolar 1, bipolar 2, cyclothymia, the general medical condition or substance use. Now, the unspecified one is supposing a medical officer or a clinical officer or a nurse who is seeing patients at the outpatient. This patient just presents with acute agitation. There is no further history, you have no other information. But the patient is presenting with the symptoms that I'm going to describe of bipolar 1, bipolar 2, cyclothymia, but you don't have adequate information to make that diagnosis, then that is when you talk about unspecified bipolar disorder. Now, mnemonics are a group of letters that help us remember. Medicine is quite vast. You may not be a psychiatrist, but you may need to quickly identify some symptoms of somebody who presents as having bipolar mood disorder, or you're suspecting. You want to make a quick diagnosis. So what happens? First, the patient will present with an elevated, expansive, or irritable mood. Now, if they have an irritable mood, then you need 3 of the criteria I'm going to describe under dig first. to diagnose this person with a manic episode. If they only have an elevated, expansive mood, then you will need 4. So what is dig fast? I want you to think of this dog that is trying to dig a hole somewhere. And look at it. Just see how fast it is digging using its paws, the front limbs, and it is really digging. So what is this supposed to tell us? One, this person becomes very distractible. They're easily distracted by the environment. So they may not be actively listening to what you're saying because they're distracted by, sorry about that. They're distracted by people who are passing. They're distracted by somebody else who is saying something. Second, they may be impulsive. So they take risks, and this means these risks may be financial. That is why you might find somebody who is dishing out their entire salary to passers-by. Or they have decided to donate their entire salary or even an investment, just give it out for free without much thought. In addition to that, they may have some other decisions, including probably risky sexual behavior that they're not in control of. This particular individual may present with grandiosity, or they feel too confident. And this is when they feel like they're president, or, I mean, they're very important people in society, and they start behaving as such because the grandiosity is a delusion. A delusion is a false, unshakable belief. You can't convince them otherwise. If they're actually the president of this country, they will behave as if they're the president of this country. And you're not able to argue it out with them. Then they present with flight of ideas, and they also have an activity increase. What is this activity increase? Supposing they actually have an increased amount of energy. So somebody will walk from Nairobi to Nyeri or to Mombasa tirelessly. They will walk. The person will engage in cleaning all day and all night. They have this immense amount of energy, and therefore they engage in goal-directed activities excessively. They have decreased need for sleep, and they tend to be very talkative. Now, I want us to quickly differentiate between mania and hypomania because it's important for us to know, or for us to differentiate between bipolar 1 and bipolar 2. I want us to go through the various parameters. The first one is the duration. Now, a manic episode, this person will have dig fast for a week, at least 1 week. And these symptoms are present most of the day, every day for the 1 week, or any duration, including 1 day, in case or if they did need hospitalization. So hypomania, the patient may have the symptoms, but a duration of 4 days. So people will notice out there that the person is a bit hyper. For about 5 days, they're talking a lot. I mean, they look excited. They're actually looking more excited than usual. And this is over 4 days. Now, when it comes to mania, the social or occupational dysfunction is a must. Now, the social and occupational dysfunction in hypomania is unequivocal. A hypomanic episode may not land you in a hospital, but we are going to see why people with bipolar 2 will land in hospital because of the depressive episode, but not necessarily the hypomania. What about disturbance in mood, change in functioning? Usually in hypomania, it will be observed by other people. The person who is hypomanic may not know about it. Now, the person who is manic actually feels like they're on a motor and everything is just happening too fast. So for them, they actually, in addition to other people noticing that there is something wrong, they themselves are now hyperactive, they're doing things, all these symptoms happening together. Psychotic features, like for example, the grandiosity, those delusions, the flight of ideas where they talk so fast, many ideas which are not interconnected. Before they finish saying this, they have started saying another one which is not related, or they take too long to get to the point. Now, those are features of mania. In hypomania, you do not have psychotic features. Now, for any of these diagnoses, you have to rule out a drug that is medication, substance use, or medical condition. Like now, for example, if a patient is a patient with bipolar 1, but the day they present to me, they present in a depressed episode, and I give them antidepressant. What happens is the antidepressant may induce mania. So for us to talk about a manic episode, then we should rule out the fact that there is any medication that has been given that could have led to that, or the substance that was taken, like cocaine or alcohol, that led to symptoms that resemble those of mania. Now, what about depression? We talked about the black and white as the ribbon colors, signifying the fact that you have extreme changes, high mood, or rather the fact that people have highs, they tend to be having expansive, irritable mood in mania, while when depressed, they are very low. They can't even afford a smile. They have problems with sleep. So it's important that we also talk about how to identify somebody with depression. And this person has to be, for example, depressed mood. They must have that every day, nearly every day, for a period of 2 weeks. For mania, we said a week or less if the person has had hospitalization. Then for hypomania, we said 4 days. For depression, it is 2 weeks. So this person may either sleep very little or sleep too much. They have very little interest in pleasurable activities. The person previously enjoyed watching TV, for example, or even playing golf. Now they do not want to hear it because the interest has gone down. This we call anhedonia. Clients present with excessive guilt, and they feel worthless, and they'll suffer from low self-esteem. They also have problems with energy, so they have very little energy and they're always tired. These clients will also have concentration difficulties. They may have difficulties with making decisions, whether to eat or not to eat, to cook or not to cook. Appetite changes. In atypical depression, patients eat a lot. On the other hand, patients may not have any appetite. To some point, some do not eat, and they will present with hypoglycemia. Then psychomotor retardation, so the person walks very slowly, does their things as if they're on slow motion. So then suicidality. When it comes to suicidality, we want to talk about suicidal thoughts, suicidal plans, and suicidal intent. And finally, suicidal attempts, and unfortunately, completed suicide. So now, cyclothymia is the third. And cyclothymia is like a mini bipolar 1, where this patient presents sorry about that, is actually a mini bipolar 2, where this client, if he's an adult, presents with 2 years history of hypomanic episodes alternating with depressed episodes. If they are children, we only need 1 year. But it's important within these 2 years of hypomanic episodes, depressed episodes, this person does not last more than 2 months without any of this, and they become dysfunctional. That is cyclothymia, a mini bipolar 2. So now they are what we call specifiers, and if a diagnosis of a manic episode is made or a depressed episode, it's important for us to say, is there anxious distress? Are there mixed features? Mixed features means the patient is alternating between mania and depression and presents with both of them. So probably the first 1 hour, they're manic, they're all over the place. And a few hours later, they're in the depressed phase. We also need to note down or specify whether they are psychotic features, whether they are hallucinations or delusions. Catatonia. We need to identify patients who are catatonic, whether they have catatonic excitement or catatonic depression. Peripartum onset, because that is one of, you can have bipolar mood disorder, a manic episode of peripartum onset. The patient has just delivered and is now presenting with manic episode or a depressed episode. Then we also have situations that are described as rapid cycling. If a patient oscillates between mania and depression more than 4 cycles in a year, that is a rapid cycle. Seasonal pattern. There is what is called seasonal affective disorder, where in winter months or in very cold months, patients present with depression. We also have seasonal bipolar, where probably somebody with a certain deadline, like maybe a finance employee. I don't want to say accountant. I don't want to say a specific. I'm just trying to say somebody with a deadline, probably at the end of the financial year, may be presenting with manic episodes around that time. And when you actually look at the history, this person is presenting with those with the manic episode whenever it approaches the end of the financial year, because that's when they have to submit all the accounts, and probably they have to submit a budget and present it to other people, and that can happen. Now, it's important that we recognize that bipolar mood disorder, whether bipolar 1, bipolar 2, has an equal ratio. Bipolar in general, the ratio is 1 to 1. But when it comes to bipolar 1, it is common, it is equal ratio, male and female. Bipolar 2 is more common in females than in males. And this we will see is because there are more depressed episodes. They're the ones that bring the patients to hospital when it comes to bipolar 2. But what about the global prevalence? It's between 1% and 2%. And it is the 6th leading cause of disability worldwide. And the age of onset is late adolescence or early adulthood. The average age of onset is 25 years. Risk factors, bipolar is more common in high income individuals than low income, and also the marital status, either separated, divorced, or widowed. And there is also the genetic component that I'm going to describe. Now, let's talk about etiopathogenesis of bipolar. Now, when we talk about the epigenetics. This is a situation where we are describing how our behavior affects the DNA expression. And this is something that has been described as reversible. It doesn't delete any DNA parts or anything, but it is something that can influence the myelination, the maturation, and this does affect, and it is thought to be part of the pathogenesis of bipolar and related disorders. What about environmental factors? Childhood trauma, what we call ACEs, adverse childhood events. That is why it's important that children are protected and that we don't expose them to trauma. Substances, including alcohol, including cocaine, will give symptoms that are similar to those of bipolar 1, bipolar 2. They'll actually give the same presentation, but now it is related to the substance. Stressful events. Let me describe stressful events. We have what are called entry events. Supposing I passed an exam, or I got a promotion, or I became CS of this country. It can be a trigger for a relapse. Those are what are called entry events. They are good things. But they are exit events, where probably you have lost a loved one, you lost a job, or suddenly the NGO funding has come to a stop. And these are things that happen from day to day. So when we talk about stressful events, we are talking about entry and exit events. They can lead to relapses. Then neuronal changes, circuitry in brain matter, and this explains, like, for example, antidepressants. Why, if you start an antidepressant today, you don't expect instant results. You may need 10 to 14 days for it to start working. And you may need 6 to 8 weeks for clinical improvement. Why? Because of the effect on neuroplasticity of the brain. Now, the suicide risk when you're diagnosed with bipolar, believe it or not, is 15-fold that of the general population. It also accounts, like bipolar 2, because they have more of the depressed, they present with depression, they account for a quarter of the completed suicide. And they are associated with more suicidal attempts and increased depressed days. So what we are trying to say is that bipolar is a risk factor when it comes to suicide risk. So if we are going to prevent, suicide, we also have to address the treatment of bipolar, the prompt diagnosis, the treatment, and the support of people living with bipolar. In addition to that, clients with bipolar mood disorder will not probably swallow a couple of pills. They will want to point a gun at themselves, or they may want to jump from a height. And the lethal means or even organophosphate. So even in ICUs, you may find patients who've attempted suicide because of bipolar mood disorder. So there are factors that are associated with suicidal attempts, suicide deaths, so that suicidal attempts are more common in females who tend to be younger. Now, the suicide deaths are more common in males, and these ones tend to be older. And minority groups tend to be at risk of suicidal attempt, being probably lacking support, either they're single, divorced, or single parents. Then you may find that they attempt suicide. But suicidal attempts in mania are more violent and they tend to succeed more. So now when we talk about polarity, most of the suicide attempts will be done during a depressive phase or mixed phase. Suicide deaths, it's either a depressed phase or mixed phase and manic with psychotic features. So if, for example, the patient has some delusions or hallucinations, then they are more likely to end up with completed suicide. In addition to that, there are what are called psychiatric comorbidities. This means you have bipolar and you also are using substance, or you have bipolar and you also suffer from an anxiety disorder or an eating disorder. These people tend to be more predisposed to suicidal attempts, and comorbid anxiety disorders have been found to be associated with suicide death. Personality disorders, cluster B, these are people who are very dramatic and they tend to attempt suicide more. That is the borderline personality, narcissistic, histrionic, antisocial personality. Then suicidal attempts have also been found to be associated with high BMI, obesity, and as I said, childhood abuse because of the early childhood experience, adverse experiences. So now, when it comes to psychosocial, this is where social support comes in. People with interpersonal problems, problems at work, people who have who have lost loved ones, who are socially isolated, they tend to attempt suicide. Suicidal deaths, most of the patients will present within 1 week of the death. So it's important that you ask questions as regards, are these people feeling hopeless, helpless, worthless? Because then this is what probably you'll be looking at and you wonder, why did the patient die after I saw them? It's because probably they were suicidal, but that did not get addressed. And a suicidal attempt, as suicidal thoughts, suicidal plans, then those are psychiatric emergencies. Sexual dysfunction has also been associated with suicidal attempts in patients with bipolar mood disorder. And then patients who have rapid cycling, the ones who have more than 4 episodes, 4 different cycles, depression, mania, hypomania, depression, more than 4 in a year, or those with anxiety, atypical features like those of sleeping too much, eating too much in atypical depression, or suicidal ideation. Those ones tend to attempt suicide more. Suicidal deaths are associated with hopelessness, psychomotor retardation, and these are symptoms of depression. So supposing this patient came to you, what else could be going on? Or what are the differentials? Major depressive disorder, persistent depressive disorder was formerly known as dysthymia, but it has now been reclassified. And it has the same criteria as cyclothymia, where this person for 2 years in adults or 1 year in children has had low mood, low appetite. They have a mini major depressive disorder. They don't meet the criteria for depressive disorder, but they have the siege caps. Remember that we talked about the mnemonic for depression? They have all those symptoms, but they haven't reached that threshold of probably 3 weeks, but they are on and off for the last 2 years, and this person doesn't last more than 2 months without any of these symptoms. And remember, these symptoms are more than one, not just depressed mood. There is lack of interest in pleasurable activities, among other symptoms. Then psychotic disorders like schizophrenia, schizoaffective. Schizoaffective means you're presenting with the symptoms of schizophrenia and those of a mood disorder, whether it's mania or depression at the same time. Delusional disorder, on the other hand, is you only present with depression, with a delusion, which is a false, unshakable belief. Then the personality disorders listed below, those are cluster B personality disorders. They mimic bipolar mood disorder because, like in borderline, the patient has extreme mood swings. They tend to be dependent. They don't want to be abandoned. They have fear of being abandoned. And these patients will present as if they have bipolar and related disorder. Narcissistic personality disorders, these ones tend to be full of themselves, they lack empathy, and they think everything is about them. And they do not have, they don't have any empathy. And for them, it's about being very, I would say, important, for lack of a better word. And then the antisocial personality disorders, these individuals have no regard for other people's rights. So they will steal something, not because they need it, but to throw it into the trash. These are people who do not respect people's rights, they lack empathy also, and they most of the time are in the criminal justice system. Now, comorbidities, I had mentioned this briefly about substance use, panic attacks, social phobias, specific phobias, personality disorders, and impulse control disorders. Let me describe this one. Attention deficit hyperactivity disorder can coexist with the bipolar and related disorders. Oppositional defiant disorder, where the child does not have any regard for authorities, then that can also present at the same time. Conduct disorder, where this person has cruelty to animals, humans, also may predispose them to antisocial personality later. They also lack empathy. These impulse control disorders could coexist with bipolar and related disorders. Now, remember, we have taken a history. We have examined this patient. We need to investigate patients extensively. And of note is, for example, thyroid functions. Patients with low thyroid functions tend to present with depression. Those with high thyroid functions tend to present with anxiety. So in addition to ruling out medical causes of the bipolar and related disorder, you also need to find out whether this person has a total blood count that is normal. Maybe they've not been eating, or they've been having these goal-directed activities. They have been walking for several days. They're dehydrated. What are their renal functions like? What is the cardiac function? Especially if the client is above 40. You need an electrocardiogram, you need an echo. Then brain imaging is very necessary to rule out frontal lobe syndrome, where patients would present with disinhibition. They will have altered behavior or a sudden change in behavior. And this imaging can help us find out what exactly would be the cause of their symptoms and address it appropriately. Now, let me talk about treatment guidelines. Treatment guidelines are by the Canadian Network of Mood and Anxiety Disorders. We call them CANMAT, and the International Society of Bipolar Disorders. The International Society of Bipolar Disorders is one among those who came up with the World Bipolar Day and the Asian Network of Bipolar Disorders, among other organizations. So now I will quickly describe evidence so that when I go to the specific treatment, you can tell which is the one that is best vis-a-vis one that is neither here nor there. So let's start with level 4. Level 4 is the least amount of evidence. It's Dr. Mushero saying, I have treated patients with this drug or with this mode of treatment, and it seems to work. But there is no uncontrolled randomized controlled trial. I mean, there's no controlled randomized controlled trial, and it's only based on anecdotal reports. Then number 3, you have one double-blind RCT, random controlled trial, randomized controlled trial, and you have a sample size of between 10 and 29 patients. Level 2, they have more patients, and they have a wider confidence interval with a meta-analysis. Then level 1 has a meta-analysis with a narrow confidence interval and more patients. So let's go. Now, psychotherapies. Our guests talked about psychotherapy. What are these psychotherapies? I'll talk about the first line. Psychoeducation, being told about your condition, what are the risk factors, what are the red flags, and how can you make sure you're stable. That is psychoeducation. So for maintenance in bipolar, it is first line. Then there is cognitive behavioral therapy, there is family-focused therapy, and interpersonal and social rhythm therapy. Peer support also has some advantage. Now, the others, we are including mindfulness, including family and caregiver interventions. We don't have enough data. It's insufficient. Now, even online interventions, we don't have any that have been shown to be either level 1, 2. I mean, level 1 or 2. Now, what about medications? The gold standard for treatment of bipolar mood disorder is lithium. Lithium is very effective when it comes to monotherapy, followed by quetiapine, and the others go down that list. But what about if you're combining? That's the middle column. You use quetiapine, you can add lithium or divalproex. You can also use aripiprazole plus lithium or divalproex. What about second line? Olanzapine, carbamazepine, and even ECT, electroconvulsive therapy, they have a role. Now, what about depression? Remember we said if you have bipolar 1, you need a past or present manic episode or mixed episode. So you can also present with depression when you have a diagnosis of, bipolar 1 mood disorder. So what is the first line? Divalproex. But I need to put a disclaimer on this because divalproex has been associated with teratogenicity, especially when it comes to pregnancy. So any patient or any female patient of the reproductive age should not be on divalproex if they are not on folic acid because of the risk of neurotube defects. There are also other studies that have shown that divalproex is also, it also has adverse effects on the male. So as much as possible, we have to if we have to prescribe divalproex, then it has to be accompanied by folic acid. So that's the first line. The second line for the bipolar depression is either an SSRI or bupropion. But these ones are adjunct therapy. I will refer to the treatment for our guests so that at least you understand. Like, for example, he talked about sodium valproate. He talked about fluoxetine. So this is where we are at. We are talking about a mood stabilizer, which is divalproate. We are talking about an SSRI like fluoxetine. Now, second line, we have quetiapine, we have lurasidone, and the list continues. Now, maintenance. I want to clarify that the patient who comes in a manic episode will be stabilized. So they need to be maintained on medication for a lifetime because bipolar is a serious mental illness. And in addition to that, it is chronic. So we need lithium, we need quetiapine as first line, second line are as listed. You will be given these slides. Third line is carbamazepine. You can also use chlorpromazine in low resource settings, haloperidol, and what is called repeated transcranial magnetic stimulation. This is stimulating the brain directly. Now, when it comes to acute management of mania, we have first line, we have second line, we have. So I will also share these slides so that you have something that you can refer to. But let me quickly talk about the side effects. There is no medication without side effects. And the reason why patients run away from us is one, weight gain. So it's important that you look at the weight. I mean, the weight of the patient, and also encourage them to exercise and to eat healthy. Now, gastrointestinal symptoms, nausea, vomiting, diarrhea, especially with lithium, the fact that we have a slow release lithium has made this less, the nausea, the vomiting, and the diarrhea. Now, renal toxicity, any patient on lithium has to get serum lithium results every 3 months, plus renal functions, liver functions, and thyroid function. So that you should not give lithium and the patient disappears on you. They need to be monitored. Hematological effects, carbamazepine, leukopenia, clozapine, which is used for treatment resistance, is also quite notorious for hematological effects. What about cardiovascular effects? Lithium, endocarditis, cardiomyopathy. Remember, this patient may also be using alcohol, which can also give them cardiomyopathy. Endocrine effects, that is why we need thyroid functions, we need parathyroid hormone levels. And for valproate, you also need to address the issues of oligomenorrhea and hyperandroism. Now, we use antipsychotics for treatment of bipolar mood disorder because it's a psychotic illness. Now, remember, risperidone, amisulpride, and palperidone can actually cause hyperprolactinemia. So you might find our female patients are lactating without being pregnant or having delivered, and you might have males with gynecomastia. Kindly be observant. Then now, when it comes to cognition, lithium, lamotrigine, valproate, especially valproate and memory loss, then there is sedation, and the big elephant in this room called metabolic syndrome. We have second-generation antipsychotics, like, for example, olanzapine, quetiapine, we have aripiprazole, lurasidone, but they're actually associated with metabolic syndrome. So they have less side effects than the first-generation antipsychotics, but the problem we have is weight gain, high cholesterol, name it. So now, I want to talk about screening. I hope this is clear It is called a mood disorder questionnaire. It has 15 items. So I would encourage you to find it online and possibly see what an empirical patient may score, or ourselves. We can even score ourselves. But the interpretation is that if you have more than 7 scores, because a yes is a one point, if you have more than 7 out of the 13 symptoms, and for number 14, you have said that indeed it is contributing to these symptoms have been over a certain period of time, and they are contributing to your dysfunction in number 15, either as a moderate problem or a serious problem, then you need evaluation. So I would like to thank all of you for your keen interest on joining us and being part of this webinar. And I'm now ready for any questions or any clarifications, any comments. And over to you, Dr. Cheptoo.
Thank you so much, Dr. Musheru. So there's several questions that were asked from earlier on. I will just read some through as you try to answer some of them. The first question is from Samuel Onchere. He asked whether bipolar was the same as what was called the manic depressive psychosis, which I believe you might have answered in one of your questions, in one of your slides. Then someone else, that is an anonymous attendee, who's asked whether there's a reliable assessment tool to diagnose symptoms of bipolar disorder. And then Ngina Kahura also has asked whether the severity of depression in cyclothymia differs from the severity in bipolar 2. Maybe you can start with those 3 before we continue.
Thank you very much for those questions. Indeed, manic depressive disorder is one of the previous classifications of bipolar and related disorders. Number 2, is there a reliable tool used for diagnosis of bipolar and related disorder? We have a screening tool called Mood Disorder Questionnaire, which has 15 questions, but it is a screening tool. It is just to give an idea, could you be suffering from bipolar and related mood disorder, but you need a mental health professional who has been trained to evaluate you, to also request for any investigations they deem, that may be required to confirm the diagnosis of bipolar. Then the other one was about, there was a reliable tool. Dr. Cheptoo, please remind me the other one.
Yes, Margaret had
severity.
asked whether she had asked whether there's a reliable tool. Did you answer that?
Yes, I did. I talked about the Mood Disorder Questionnaire as a screening tool, but you need an evaluation by a trained mental health professional for the diagnosis of bipolar and related mood disorder. Now, okay. I've remembered the question. The severity of depression in cyclothymia, does it differ from that in bipolar 2? The difference is, in cyclothymia, for an adult, you need, one, the depression in cyclothymia does not meet the criteria of a major depressive disorder, and it does not meet the criteria, and then the fact that it is there for 2 years for an adult or a year for a child, and it has to be such that in the 2 years or 1 year, respectively, you don't have any 2 months you have stayed without the symptoms. So indeed, the severity is less, but it still causes dysfunction. So that is why we said the cyclothymia is like a small version of the bipolar 2. I hope I've answered that question.
Thank you so much, Doc. Yes, I believe you have. I hope Ngina has been answered. And there's someone who's asking about CPD points. I'll confirm for you. And then Rukaya Goralwala again has asked the same question that you have already answered, and you mentioned that there is indeed a reliable assessment tool, but then it has to be carried out by an experienced and a trained practitioner. So Jacinta Madenge is asking, what's the effect of ECT?
Thank you for the questions. If I could go back a little, when it comes to the assessment tool, remember we said mania and depression. There are also assessment tools that are used for screening for depression, like the Beck's Depression Inventory, the Patient Health Questionnaire, the PHQ-9. There is also a PHQ-2, which asks 2 questions, whether you have had a depressed mood, whether you have lacked interest in pleasurable activities nearly every day or every day for the last 2 weeks. So those are also other screening tools. Now, the effect of ECT, ECT is a treatment that is thought, one, to be very effective when it comes to emergencies. A patient who is pregnant, a patient who is not feeding at all, a patient who is not responding to medication, or who, if you give medication, it's a contraindication in terms of in their presentation. What is the effect of ECT? ECT is thought to, one, stimulate the brain, because then you stimulate the brain directly using the electrodes. They resemble headphones, and it's in the temporal region, the temporal region. So the temples, and that ECT is administered under general anesthesia when the patient is not aware at all. And when you stimulate the temples, it produces a fit, because it's in the temples, and that is the area that produces a fit. And that fit or convulsion increases the blood supply, oxygen supply to the brain, and has an effect on the neurotransmitters. There are neurotransmitters in the brain, for example, serotonin, which have been found to be low in patients with depression and anxiety. High dopamine, which has been found to be high in patients, for example, with schizophrenia, or patients, or high serotonin when it comes to bipolar. So then what happens is that the changes in the brain, remember I talked about the fact that the brain structure also has an effect when it comes to the etiology of bipolar mood disorder. That is how ECT is thought to work. And I hope I have answered that question. The adverse effect, headache after the procedure, we give a painkiller. The other adverse effect is temporary memory loss, and usually within 3 months, the memory is back.
Thank you, Doc. That has been quite insightful. We have a lot of questions. Let me see if I can try. I mean, a couple of them. We try and answer 3, and then I see what the remaining ones are. So I'm seeing you answering others on the chat box. So you can find some of the answers on the question and answered area. So someone is asking, kindly give us some information on bipolar and aging, and what to expect as the patient ages. And then there was someone who also asked, what is the difference in long-term prognosis between bipolar 1 and bipolar 2 mood disorders? And then someone else asked, between environmental and genetic risk factors, which one is more common? Then we can proceed from there.
Okay, thank you for the questions again. Information on bipolar and aging, and what we expect as the patient ages. Now, that depends on many factors. Remember, bipolar is a I would say it's polygenic. There are the genetic factors, there are the environmental factors, there is the epigenetics, there is the brain structure. Now, remember when we are aging, our brain tends to shrink. We may have other issues, including dementia setting in. Now, I would want probably some more time to research on what would be the picture like in the aging population. You see, most of the research is about the age of onset, but I haven't come across specific studies that talk about bipolar in the aging population. So that I may need to refer. But what would happen is if, for example, a patient is stable on medication, then they're likely to live longer. They are likely to manage their medical, they're able to manage any medical conditions that may emerge, like hypertension, diabetes. If they're living a healthy lifestyle, they will not be obese. And I would say the earlier you diagnose bipolar and start on treatment, and then get all these interventions, psychotherapy, get support groups, get the family members psychoeducated, then this person is likely to live a better life when it comes to aging. You see, aging is about adding years, but there is what is called growing, where you can add life into this person's years. So such that I would really recommend prompt diagnosis, prompt treatment, so that the cause of the illness, much as it is the cause of the disorder, much as it's chronic, it's a serious mental illness, people can still live normal lives without relapses. Now, the prognosis between bipolar 1 and 2, it depends on many, it depends on family history. It depends on whether this person is on treatment or not. If they have comorbidities, like, for example, substance use, if, for example, they have attempted suicide, I would say there are many factors. I would not be able to give. So the prognostic factors depend on also whether you have good social support. So as much as possible, treatment of either the bipolar 1, bipolar 2, none is better than the other, because they both cause dysfunction. So whether you have bipolar or one is diagnosed with bipolar 1 or bipolar 2, what is important is, were they diagnosed? Are they on follow-up? Are they on treatment? Are they leading productive lives? And then take care of any comorbidities, if it's anxiety, if it is substance use, and then after that, support. The prognosis is likely to improve. Then about between environmental factors and genetic risks, which is more common, it's a combination. It's not possible for us to separate environmental and genetic, because remember, this person who is genetically predisposed is living in an environment. But the beauty about environmental factors, like adverse childhood events, you can prevent them. You can, one, there can be sessions on parenting and how people probably lead lives which are without making children predisposed to trauma, remove substances out of the equation, manage stress. So the environmental factors, they are things that are modifiable. The genetic risk, now that becomes a problem, but even then, you still can live a productive life if you're on treatment.
Thank you, Doc. So, before you go to another question, and like it's almost around the same question, someone has asked, is bipolar primarily a brain chemistry disorder and perhaps genetic, which you've actually mentioned some in one of your Nini slides and also in one of your explanations. Then someone, okay, they went ahead and asked, is everyone equally likely to develop it? Lastly, is bipolar a spectrum, and are we all at one point of the spectrum? That's an interesting one.
Okay, all right. Thank you for the questions. About whether we are equally predisposed, that I would say anyone is at risk of developing a condition, including hypertension, including diabetes. But there are things you can do to prevent you developing diabetes, hypertension. The same thing. We are all at risk of developing bipolar mood disorder or any other mental disorder. But you can, as I said about the environment, you can avoid substances, probably deal with traumatic events, seek support if you're having trouble coping with bereavement and things like that. That would prevent, for example, you relapsing or probably getting a relapse or even probably the first episode. So it is indeed true, the fact that there are many factors, both environmental, genetic, the structure of the brain that predispose us to developing bipolar and related disorder. Now, the question of whether bipolar is a spectrum is something that is still undergoing research, because then there are many other conditions which would also be on the spectrum, because then we don't know whether autistic spectrum disorder, schizophrenia, OCD, bipolar, they're all in the same spectrum. All we know is that, one, we have a specific criteria for diagnosis. And now, for anybody to be on treatment or to necessitate treatment, then you must be dysfunctional. There has to be some clinically significant distress, such that socially you're not able to relate with those around you, or occupationally you're not able to perform your work, or you're not able to go to school if you're doing evening classes, or if you're a child who's then in school, you're not functioning. So I would say we stick to the criteria for diagnosis for now. As research continues, we will get to know whether these conditions are all in a spectrum and see the way forward when it comes to that. When it comes to further treatment. But research is ongoing, and we look forward to some of these answers.
Thank you very much, Doc. I am seeing a lot of questions. I think some of them we will have to note them down. I think I can go up to around 8:40, and then afterwards we'll have to call it a night. So let me ask a few of some questions on the chat area before I come back to the question and answer box. So one asked, is in acute bipolar manic episode, from your experience, what is your preferred go-to in terms of medical stabilization? And then another one was proposing that we could do a series of mental illness in children and teenagers. We will come back to you. We will consider that, Mildred. And then what is the best drug for insomnia in bipolar 2? And then what are the most effective long-term injectable depot preparations? Oh, sorry. Again, I've given you 3. Let me just add one more. Can patients with bipolar and who are compliant on medication safely drink alcohol or use other social mood-altering substances? Yes, please.
Thank you very much. Now, my preferred go-to medication for a manic episode, I would still want to refer to the guidelines because we have first line, we have second line, we have third line. One, it depends. If it's an acute manic episode, the patient may require hospitalization, may require injectable antipsychotics, would require mood stabilization. Then once it comes to the maintenance phase, lithium is the gold standard. But if we are to talk about short-acting antipsychotics, like for example, zuclopenthixol Acufase, haloperidol, those are the medications that we use to stabilize patients unless there is a contraindication. Now, when it comes to oral for the acute stabilization, then it depends on, for example, what is available at the facility. And we would want second generation, so the newer medication. And then, so that is acute and maintenance. So when it comes to insomnia in bipolar 2, the most likely reason why somebody has insomnia in bipolar 2 is first to find out the underlying reason or the underlying cause, which is most likely the depression. So treat the depression. There, for example, antipsychotics, the newer ones like quetiapine, which is the gold standard when it comes to bipolar 2, and it manages insomnia very well. So the immediate release quetiapine would be my go-to medication. Avoid hypnotics because of the risk of addiction. And if you give them for more than 14 days, for example, the benzos, then you have rebound insomnia, rebound agitation, and the patient will actually be worse than if you had stabilized them on something more specific like quetiapine. Now, when it comes to effective depot preparation, now it depends on the setting and what is available. But for example, if you have a patient on, who is stable and has bipolar 1, then zuclopenthixol would be useful for that patient. Zuclopenthixol depot, what is called Clopixol depot. Now, if you have bipolar 2, you may want to use flupentixol, which is fluanxo depot. Now, remember, you will also need a mood stabilizer or an antidepressant. If you would allow me to refer to our guests talked about being on fluanxo, which is flupentixol, aripiprazole, which is a second generation antipsychotic, or what we call atypical, A, then typical, atypical, being on an antidepressant, and being on a mood stabilizer. So we would want, as much as possible, the patient to be on fewer drugs, but there are some patients who still need to be on quite a number of drugs. So effective depot preparation, it's important to look at whether the patient has bipolar 1, 2, and then also follow up the patient so that if they're having side effects, then you're able to identify and maybe change. But as a rule of thumb, you need to have a patient who is not naive to put them on a depot injection, because once you inject it into the muscle, it's secreted in small amounts throughout the month or throughout the 2 to 4 weeks, because depot preparations we can give every 2 to 4 weeks. So it's important that you start them on oral medication, and then after that, then now transit them to a depot injection. Then before I leave that space, what I've been talking about, flupentixol, zuclopenthixol, fluphenazine, all those are first generation. We have second-generation antipsychotic depot injections, some which are monthly, others that are 3 monthly, and in future, 6 months. Now, you need to start them, like for example, paliperidone is the second-generation injectable I'm talking about when it comes to monthly, 3 monthly, and 6 monthly. We don't have the 6 monthly in our market, but we are hopeful that we will have it, so that the patient has 2 injections a year. The 3 monthly, they have 4 injections a year. Then the monthly one then is as we prepare to transit them to the 3 monthly one. Now, if you're to begin a patient on that, you need to put them on paliperidone tablets and see how they respond, or the sister molecule, risperidone, and put them on that for at least a month to see how whether they're able to tolerate. Remember, I also talked about risperidone and hyperprolactinemia. So you may also need to look at those when you're choosing the medication for the patient. I hope I've answered the 3 questions.
Yes, Doc. So we need to wrap up. But before we go, there's one that I would like you to answer. Someone has asked, can you marry a bipolar man? And if you have a child with him, should you take the kid for screening? And both children are 5 years and 2 years old, and he is also epileptic and on Tegretol. He wants everything done according to his thoughts and wishes. And I think I saw another one, how to differentiate impulsive symptoms of ADHD and mania in bipolar mood disorder. And then, yeah, you already mentioned about childhood trauma connecting to bipolar issues. You mentioned that. And someone wanted you to clarify which tool that, the tool that you said had 16 questions, but he's only seen one that has 15 questions. So you need to clarify with him.
Okay, let me start with the last one about the mood disorder questionnaire. It has 15 questions, 15. Not 16.
Okay.
PHQ-9 has 9 questions. It checks for depression. Then BDI, that is Beck's Depression Inventory, has 21 questions. If it is a PHQ-2, which is a mini version, it has 2 questions. Now, how do you differentiate impulsive symptoms of ADHD and mania? Now, we said ADHD is a differential, can coexist with mania. Now, the difference is the mood, the symptoms of mania are episodic. We said they're not permanent, they are at intervals. When it comes to ADHD, the impulsive symptoms, if you have the impulsive type of ADHD, then those ones are constant. They don't wax and wane. ADHD has 2 types of symptoms. You can have the inattentive type or impulsive and hyperactive type. So if you're diagnosed with the impulsive hyperactive type, then your symptoms are constant. They don't wax and wane. Then also, you wouldn't be able to meet the full criteria of a manic episode. Remember the dig fast I talked about? You wouldn't be able to meet that. Now, the practical question of would you marry a bipolar man? The answer is yes, because bipolar is a serious mental illness, but it's manageable. And the more we say a bipolar man instead of a male or a husband living with bipolar mental illness or bipolar disorder, then we add to the stigma. And usually what happens is whenever the person has gets irritable or maybe asks a question looking rather assertive, they're asked, have you taken your medication? Then now that is the beginning of war. So if you want, for the sake of peace, the best thing would be to take this person, just like somebody with diabetes, and the fact that sometimes they may go into hypoglycemia, or they may have hyperglycemia, or the blood pressure may be high in a hypertensive patient, it's the same analogy. Now, the kids are 5 years and 3 years. They may not need to be taken for any evaluation. Bipolar does not, it's not complete penetrance like hemophilia. Hemophilia, if the father has hemophilia, then the son automatically has hemophilia. So that is complete penetrance. When it comes to bipolar, it skips generation. And sometimes patients with bipolar, they don't have anybody in their family with bipolar. They may even have somebody with schizophrenia. So then what you can do is to protect your children from adverse childhood events, to prevent them, teach them from an early age not to use substances, and as much as possible, attend psychoeducation sessions where you now can understand how you can support this person as the father of the children and see how best you can support it. Now, epilepsy, the person also has epilepsy. Yes, we have situations where somebody has bipolar mood disorder and they also have another neurological condition, which now is epilepsy. The beauty here is the Tegretol or the carbamazepine they're using is both a mood stabilizer and is an anti-epileptic drug. Now, they should never use alcohol because then alcohol reduces the threshold for the seizure. So then this person is likely to get into seizure. Also, if they use alcohol, they are likely to be more impulsive and it will interfere with the medication that we are giving, such that it is less available for the body to use or the brain to use. So substances should be out of the question. But the family can have a near normal life unless the patient relapses. And when the patient relapses, you know the red flags now from Dig Fast. Rush the patient to the nearest hospital or the nearest clinic. Let's get it clear. If the person is just having 1 or 2 symptoms, mild symptoms, they don't need admission. They can actually be managed by the nearest psychiatrist without needing admission. Our guest said for 3 years, he has no admissions. Yet, he has suffered from bipolar mood disorder for more than 20 years. Now, the last one. Can we safely drink or enjoy some weed cookies, weed cake, or smoke cannabis leisurely? The answer is no. It is not advisable because, as I said, in addition to the bipolar and related disorder that you have, now you will also have a substance-induced or related bipolar related and related disorder. So it's actually going to be double tragedy for you.
Thank you, Doc. I think we need to end there. Thank you so much for a good presentation. I see so many people had questions. It's actually an important topic and we needed a lot more time to discuss this. Maybe if you can share your contacts where people can be able to reach you so that they can ask more questions, and we can try and also organize maybe another webinar that can be a follow-up after this. Also, for those who are asking for the slides, we have them uploaded in our website, the KMA Physician Committee website, Physician Wellbeing Committee website. So you will be able to find them there. For the ones who are asking about CPD points, I've been made aware that the CPD points are going to be available for doctors. And then before we finish, Dr. Ida, our co-convener for the committee, has passed her regards, and she has thanked you for a great webinar. And Mira Asani has invited you to visit the rehab facility on Jumbi Road. I think I will forward her contacts. Then maybe you can talk more with her about that. So that being said, thank you, everyone. I am grateful that you were able to learn about bipolar. We were able to create awareness, and going forward, and also in your daily interactions. If you have family members, if you know anyone who has bipolar, kindly be kind to them and support them in any way possible. And with that being said, may we have a great night. Thank you, Dr. Musheru.
Thank you for having me, and good night.
Good night.